Yes, sir.
Just see whether you can record. Is it possible for you to record? Or
No, sir.
okay, so well, so let me do this. I will record it, but when I hand over the host ship to Professor Neville Perra, you remind him to record that bit. Is that all right?
Yes, sir. I will, sir.
Right. Okay.
Thank you, sir.
Right. So can you see
Yes, sir. We can see the screen,
see the
sir.
PowerPoint? No. Okay. So I'll start recording from now onwards.
Recording in progress.
Right. So good afternoon. Over the next 45-50 minutes or so, let's just run through some case scenarios where patients come up to us with hematuria or blood in the urine. So I'm going to go through a few case scenarios and also just introduce you to some concepts of blood in the urine as well. So these are very common scenario where we are called in to help out with a young female with diabetes, typical loin to groin pain, hematuria, oral antibiotics for 5 days, 101 fever. So what are your thoughts on this? What is the possible diagnosis, and how will you proceed with management in this scenario? Anybody, just unmute yourselves and just join in the conversation. That's fine. So what do you think could be the diagnosis? There is hematuria, typical loin to groin pain.
So this could be a urinary calculi complicated with UTI, sir?
Yes, absolutely. So that the classical loin to groin pain, I mean, you do see it in patients, the classical loin to groin pain, very severe pain, very colicky pain, combined with hematuria. It's almost diagnostic of a calculus. Now, as you correctly mentioned, the important point is that there is some UTI going on, right? Now, is it just a UTI? Would you say a UTI, or would you? Is there any other sort of possibility? Yes, definitely, it's a urinary tract infection. But can you or anybody else sort of further, how shall I say, classify this urinary tract infection?
Upper tract infection?
Yes, upper tract infection. Why are you specifying and saying it's upper tract infection? Yes, there is definitive indication that there is some element of infection, right? There is
Allergies and fever, sir.
Yes, that's right. So that is fine. Anything to say that it's upper tract fever? Obviously, from the diagnosis, we have got that it is a. What have we got from the diagnosis? What did we say? We know it is a calculus, ureteric calculus. So if it is a ureteric calculus, then what type of obstruction are we seeing here? Where is the obstruction that you see?
So backflow obstruction, sir, to the pressure back to the K-leak system, sir.
Yeah, I mean, so basically it is obviously not the urethra and the bladder that is obstructed. This is an obstruction of the ureter, which will cause blockage to the ureter, pelvic calyceal system, and as you correctly said, the backflow pressure, which will go on to the pelvic calyceal system, and from there onto the pressure will mount onto the nephrons. Right, so that is the basic pathophysiology of this, and there is 101 fever. Any other sort of worrying factors in this scenario? What are the So, right? In scenario, I mean, you asked any urologist, we will see this, and sometimes we will see diabetics. I mean, recently I had a 63-year-old lady coming with just high sugars and looking very ill. I mean, very, very nicely, the family had picked up that she was unwell and brought her, and her CRP and all the other white cell count, serum creatinines were sky high. Apyrexia. She was completely apyrexia because of this diabetes, right? You need to understand that diabetics are immunosuppressed and they are immunodeficient, so therefore they will not clearly have the classical features of sepsis and may not have temperature. So these are this is worrying, right? Their ability to mount a defense is poor, so therefore they may go into a situation called what? What is the situation that they could go into? So you know there is obstruction, there is blockage due to the stone, there is a definitive infection which is very clear cut, and therefore this can very easily almost, it may have proceeded or it may proceed to what situation? What is the dangerous situation that you're concerned about from beyond just a UTI?
Urosepsis?
Yes, absolutely. Urosepsis. And what are the other sort of, now with an obstruction and the pelvic calyceal system getting obstructed, what are the stages of infection that you can have? So urinary tract infection and upper tract infection. Beyond that, what are the other things that can happen? Urosepsis is sort of almost the one end of the spectrum. From a UTI to urosepsis, what are the other stages that can happen?
Pyelonephritis.
Yes, absolutely right. Pyelonephritis. Anything else? Something a bit more advanced than pyelonephritis itself?
Pyonephrosis.
Absolutely, yes. Pyonephrosis. Okay, so these are kind of stages of all of these, right? And these are the kind of things that can happen in these obstructed patients. These are very, very critical patients, and you need to rush and get these guys in if you want to firstly save nephrons. Now, as a urologist, nephrologist, physician, clinician, medical student, that is our first priority, to save the nephrons here. Then, of course, to save the life, right? So if you want to save nephrons, because you know that pyonephrosis means, pyelonephritis maybe, but pyonephrosis means within 24-48 hours, you're looking at a massive permanent reduction in kidney function. The kidney is going to be permanently scarred, right? So these are huge medical emergencies, right? Okay. So what do you want to do now? What's your plan on this patient? Patient has come to your clinic or the OPD or your general practitioner, private sector even, right? You're sitting there and this patient is almost being carried by the family member and being brought. So what do? So they have given coamoxiclav, right? So can I change the oral tablet? Obviously the coamoxiclav is not working. What do you think? Shall I change the antibiotic? Maybe add on some Cipro and try how it works? What are your thoughts?
So first we can give pain relief.
Sorry?
First we can give pain relief, sir.
Okay, yes, I agree.
So we can give IV antibiotics, and also the definitive management would be to decompress the system, sir.
Yeah, so I completely agree with you. Antibiotics and along with antibiotics, get into the habit of saying what? Just like saying U and E's, just like saying U and E's, urea and electrolytes, right? Creatinine and electrolytes. What is antibiotics? What is the other word that should come in straight away?
Cultures.
Yes, yes, absolutely. Right. So cultures, urine and blood. Okay. These are very ill patients, right? So, and somebody mentioned very clearly that they are going to do decompression, right? This alone, cultures and antibiotics and pain relief alone is not going to treat this patient. You have to decompress the system. So all in all, my plan of giving oral Cipro and telling the patient to go home is a killer, right? That is not absolutely acceptable, right? That is not acceptable. So what is the first thing that you think of? What is the main thing that you decide on? Do all of this? Yeah.
Whether patient needs medical expulsion therapy or a surgical decompression.
That should be the least MET or surgical stone removal. I would say that is the least of the priorities right now. Okay. Yes, somewhere on the line, yes, but that is the least of the priorities right now. Okay. So right now, don't worry about that. Right. So what is the other thing when you are tackling a patient in OPD? What is almost the first decision that you have to make?
Admit the patient.
Yes, absolutely. Brilliant, right? The first thing I decide is I can't be just, throwing Cipro oral at this patient. I will kill this patient. First thing is I will admit the patient. This patient needs admission, probably ideally in a HDU setting, ICU setting, that kind of setting. Okay. So that is the first criterion that you do. I mean, now, I don't know whether you all are involved, but this 247 COVID hotline, right? So all of us docs, what we do is, first thing to do is we decide whether the patient needs to be admitted or not. That is what the family also wants, is this patient needing admission. So any patient you are given, state that is what the consultant and any doctor, intern, OPD doctor, all that they have to decide first of all is, am I managing outpatient or admission? Now, this patient needs admission. Cultures, antibiotic decompression, pain relief, and later, very much later, you will think of this. Okay, don't stress too much, because once you decompress, you're safe. You're fine. You can send the patient home with the decompression and get back. Okay, so that is the basic management that you have to think of. Let's move on. So testing wise, what do you do? So obviously you can get an X-ray or a CT, ultrasound. That's the massive dilatation of the pelvic calyceal system. Can you see? That's the cortex. Okay. So stone will be along the ureter somewhere, right here. So this is at the 4-5 level. So just probably may have dropped into the upper ureter, or maybe at the PUJ even, right? So large stone with a massive obstruction. So this is the CT, right? Large side is different, so don't worry about that. Large stone, right? So how will you treat this stone? As somebody very clearly mentioned, decompression is the thing. Okay? Decompression. Right? Decompression of the system. Because this system probably is infected. The upper tract is infected. And if you leave it with antibiotic, this is going to turn into a collection of pus, and the bacteria under pressure will escape into the kidney and then onto the bloodstream with septicemia and multi-organ failure, etc., etc. So you got to arrest that by putting a JJ stent or from externally a nephrostomy, right? So we have discussed about these things, so I won't go too much into that, right? Later on, management of the calculus, you have tons and tons of methods of treating that. You can try some shockwave lithotripsy, or you can go ahead and do a urothelial endoscopy, open or laparoscopy, and get rid of this calculus, right? Okay, so those are not major difficult things for you to figure out. But in this case scenario, the thing is about picking up the obstructive uropathy, where you see pain, fever, diabetic. Because of the red flag signs, you decide on admission and do the decompression, cultures, decompression, IV antibiotics, and proceed to management. Okay?
Recording stopped. Recording in progress.
So, as I mentioned, you can give shockwave treatment, still used, but now with the access and availability of very fine instruments nowadays, most stones are tackled with endoscopic treatments, but that is something that is there out there as well, right? Okay, let's see this 62-year-old male coming with loin to groin pain, hematuria, diagnosed with a mid-ureteric calculus, no complications, diabetic, you manage conservatively. So on discharge, what do you tell these patients? What is the discharge plan for these patients? So you are managing conservatively, right? Medical expulsion therapy. What are you going to do? Tell me quickly, then we can move on to something. How about you, DHU Fernando? Okay. DHU Fernando?
Yes, sir.
Yeah, go ahead. I'm just picking names at random because you're not speaking. What are you going to do? What is the discharge plan for this patient?
Since we are managing, we are managing conservatively.
Conservatively, yes, yes. Small stone, no complications. Yeah. So what is the advice you give?
Advise the patient to drink a lot of fluids and also to watch out for.
What do you mean? What do you mean? What do you mean by a lot of liquids?
Water.
Now, what will that water cause? Now, this is a man who has a. It's not a. You can't say it's an obstructed system, but there is something in the pathway of the ureter, isn't it? So there is probable element of partial obstruction. Now you tell him to drink 3-4 liters of water. What is going to happen? Anybody?
So usually this size of calculus usually tend to pass naturally, sir.
Yes, so, absolutely. Yeah, yeah. No, what I'm pointing out is now Ms. Fernando said to drink lots and lots of water, right? So what is going to happen when you drink lots and lots of water? What is the reaction of the kidneys? You will have a
diuresis.
Sorry?
Diuresis.
Diuresis, absolutely right. Yes. So when you have a diuresis, what will happen? You will, when there is obstruction. Yes, that can happen, right? That can happen, but what can happen more is that you will get you will get sometimes more colics, right? The patient will start getting colics, right? So that's the problem with taking lots and lots of water when you know that the patient has a colic. So if you want to treat these patients, what we generally advise is, when you know there is a obstructing calculus, you tell them to take their normal intake of water. After passing the calculus, after we know that they have passed the calculus, for life, drink because this, when you say this, what are we trying to do now? Now the stone has already passed. What are we trying to do now?
Prevent recurrence.
Absolutely, yes. You are trying to prevent a recurrence because once a stone forms, what is your chance of getting a stone again? What is the recurrence kind of rates following stone formation? Yeah, over 10 years, almost 50%. I mean, some people almost will say that it's almost 100%, right? So there's a very high chance of forming stones again. So you need to prevent recurrences. But during an acute event, probably best to just tell them to take normal intake, right? What else do we do? Fluids. So you give the medical expulsion therapy. So what else do we do? I have about 10 cases. So the amount I can deal with during this 1 hour will depend on how quickly you all respond. Okay. Well, I will stop at 2:25 because Prof. Neville Perra is joining at 2:25.
So adequate analgesia?
Yeah, adequate analgesics, SOS. What else? You should have this broad plan for any patient whom you're discharging from the clinic. Any patient you are told to devise a plan and write that in a SCQ, or if your discussion is in a long case, you must have these plans. So treatment of these, what do you warn them against? About fluids, about food, about mobilization, all these things you must know. Then what are the other things? What are the other cornerstones of discharge plans?
So review in about
Yeah, when do you review these patients? Now this 5 millimeter stone, more than 95%, it will go. Do you need to review this patient?
Review in 6 weeks with X-ray KUB?
Yes, that's right. You must have some review to ensure what? Before discharging this patient from the clinic. What should you ensure?
Stone is passed and that there's no
Yeah,
complications.
absolutely, absolutely. He came to you with a problem. You must ensure that that problem is sorted before you discharge from the management, right? So tell him at 6 weeks, you must come with an X-ray ultrasound. Otherwise, you may have this stone blocking your kidney, and that can, cause a lot of problems. Also, you must give him an exit plan. You don't want him waiting at home with high temperatures. Secondarily, he may develop sepsis on top of a ureteric obstruction, right? So you must give him an exit plan. If the pain recurs and things are unmanageable, come back. We will try to get rid of the stone. Or if you develop high fevers with severe pain, Don't wait at home. That means your kidney is infected. Come. Okay. So anyway, this pain has settled, and then he does not come for clinic follow-up. Whose fault is that? It's my fault. Okay. It's the doctor's fault. Nobody else's, right? That means we have not counseled him properly, right? And what can potentially happen, right? Some of these patients, elderly diabetics, they can come later with urinary sepsis, right? So these are actual case scenarios that we sometimes see, right? I have had 2 patients over the last 14 years, 2 patients who have had to have kidneys removed, young patients with good kidneys, neglected stones, leading to pyelonephritis, pyonephrosis, chronic infection. You decompress, whatever you do, it doesn't settle. With due consideration for life, you go ahead and remove the kidney. So don't mess around with this, right? Remember, just because there is no pain doesn't mean that the stone has passed. If it just remains there, if it remains in the ureter, sometimes larger stones are the bigger culprits. They will not cause pain. Okay, so just be aware of these, right? Okay, so older gen, red colored urine, treated for culture positive UTI, his hematuria settled, and he is absolutely fine. He thanks you profusely. Can I discharge from the clinic? What do you think? Tell me.
So because he has a culture positive UTI, we must suspect, because it's rare in males, we must suspect the underlying pathology.
Okay, right. Let me clarify. Okay, so your thought about an underlying pathology is good. Always, when you have a UTI, always think of a secondary cause, at least 2, so that you pick up the secondary cause. Other thing is you prevent future recurrences. Now, actually, when you have a culture positive UTI in a 63-year-old male, older gents coming in with UTIs, I'm not just trying for you to ignore this, but UTIs in older males is a very well-known thing because of the obvious prostate pathology and bladder outflow obstruction, right? So at least you must pick up that there is a bladder outflow obstruction, okay? So it is not uncommon in older males, as you correctly said, in younger males, very uncommon. Culture positive UTI, you need to get some sort of investigation done. What are the 2 most important investigations that you would do? Of course, I have 2 investigations in mind, but maybe not a fair question. But what would you think in priority? What are the 2 most important investigations for us to do?
Ultrasound scan and PSA levels.
Ultrasound, I completely agree with you, right? PSA, bit of an issue with PSA. What is my issue with a patient with ultrasound scan? Yes, absolutely, right? PSA, what is the problem in a patient with a UTI?
PSA can be
Yeah, go ahead. PSA can be
elevated in UTIs as well, sir.
Yeah, that's right. So artifactually elevated, right? So don't do it at that point unless you find a grossly abnormal prostate which you feel is absolutely cancerous and you want to see whether the PSA is in the thousands or hundreds, right? Then it is okay. But PSA at that point, I would hold back on it. I would do it maybe at about 6 weeks, 8 weeks later, right? What is the other important test? Maybe a procedure?
Cystoscopy.
Absolutely. 2 of you mentioned this test, right? Absolutely, a cystoscopy. You must do these, okay? Few more things that in the history that you can pick up on. Is it throughout the stream? That means, is it total or complete? Is it painful or painless? Are there symptomatic urinary symptoms? Okay. Any stone history? And of course, the killer. the icing on the cake, so to say, of what? Of what disease? What is the icing? Smoking becomes the icing on what cake? What is the cake I'm talking about? The very unpleasant cake.
Bladder carcinomas.
Yeah, absolutely. Right? So bladder cancer, right? So these are very, very simple sort of things that we see. Sometimes you do the ultrasound and you see a stone also. So don't be reassured by these red herrings. Okay, unnecessary findings, thickened bladder wall. What else? As you all very correctly pointed out, I will do a cystoscopy, right? So before we go into that, what are the classifications of hematuria? So yes, there is a visible type where you actually see macroscopically. Patient will come and say, I pass red colored urine or pinkish urine or brown colored urine. That is hematuria until proven otherwise. What do you mean by microscopic hematuria? What is your definition of microscopic hematuria? When will I say occasional red blood cells in the urine? Is it microscopic hematuria? What do you think? What is the cutoff? What is the cutoff value for hematuria, microscopic? 5, 10, 100? What do you think?
3, sir.
Okay, yes, some guidelines will tell you 3, some will tell you 5, but that's sort of a high power field. 3 or 5 is acceptable, right? And also the other thing that we generally look for is we generally get to, if they are otherwise asymptomatic, no red signs, red flag signs, we will get them to repeat it at 2 weeks before a definitive indication is given to further investigate, right? What are the other types of hematurias that you know of? What are the other classifications?
Painful and painless hematuria.
Yeah, okay. So painful and painless, right? Very important. Why? What are we trying to hint at by saying it is painless hematuria?
Carcinoma.
Yeah, that's right. Painless hematuria in an older person. First, second, third, fourth, fifth diagnosis that you must entertain are neoplastic. It may be a bladder cancer, commonest, then renal cancer, prostate cancer, right? Urothelial tumors. All these can be more in painless, but remember, even painful hematurias can be cancers. Okay, so think of the other sign: older, smoker, etc., and other specific drugs, radiation, etc. Okay, then complete initial and terminal. Complete, of course, when you say complete hematuria, where is the bleeding from? Most probably from where? If it's bleeding from the prostate, is that the classical sign of complete hematuria? Is complete hematuria the classical sign of prostate bleeding?
No, sir. No, sir.
Right. Okay. So what do you mean by complete hematuria? Where would the pathology be?
From bladder upwards.
Absolutely. Perfect. Right. It has to be bladder, generally bladder or above. Right. But sometimes even prostate bleeds because the sphincter is below it. If it's nicely contracted, as it is generally, the hematuria can track back into especially when it's a large bleed, it can track back into the bladder and cause a complete hematuria. But as you correctly said, it's bladder or above. Prostate, ideally, if it's very small bleeds, they are more terminal, and initial hematurias are mostly anterior urethral bleeds. Okay, because there will be some blood in the anterior urethra with the pathology. Urine comes and washes with the initial part of urination, clears the urine, and then the rest of the micturition, middle and the terminal parts will be somewhat more clearer, right? So these are some things that you need to sort of out. And then, I mean, you all have gone through this. As I said, when you say hematuria, you have to think of, you're talking about red colored urine, right? That is in blood cells in the urine, right? but of course it can be due to hemoglobinuria, right? There is hemolysis, and the hemoglobin itself is going into the urine. So you won't see red blood cells, but if you do dipstick analysis, the hemoglobin will be positive. Then myoglobinuria, food discoloration, certain drugs, rifampicin, nitrofurantoin, porphyria, etc., and dark color urine due to bilirubinuria. All these can cause red or dark urine, right? Hematuria common causes. So we have spoken about UTI, stones, tumors, renal, prostate. BPH also can cause. And then, of course, remember there are tons and tons of other causes, right? Including medical causes, inflammation, glomerulonephritis, IgA nephropathy. So I'm not going to go into these details, but you need to have this at the back of your mind so that you can quickly go through these, including things like tuberculosis, radiation treatment, some other drugs, etc., right? Okay, so this is a very useful classification to think of hematuria and how to tackle this. My guru, Dr. Sirosha Gunawardhan, I don't know whether you all have heard of him, sadly passed away a couple of years back. He was the person who sort of really told us about this classification, and I still use this, very useful, right? Now, his main emphasis was when a hematuria patient comes, think of the age. Above 40s, the young age group, 15 to 40s, 15 to 30s, and the children, right? Why is that? Now, can you see the causes here? Not to 15, where will they end up? In the bleeding that you have seen, you have already seen a lot of them. You have seen them coming with post-streptococcal glomerulonephritis, for instance. Of course, they can be due to stones and UTI also, right? So these are the common causes there. In a young male or female, right? What are the common causes? UTI is the commonest, then the urinary tract stones, then glomerulonephritis also, IgA nephropathy kind of scenario, right? Then the above 40-year-olds. Now I have put bladder, renal, prostate neoplasms as the first. Is this the commonest cause of hematuria in over 40s? What do you think? Is this the commonest cause, neoplasms? If you take the statistics, is that the commonest cause?
No, sir.
Absolutely not. Then why am I running up behind this red herring then? Is it a red herring? Why have I put this right on top here?
Because it is very important to exclude that, sir.
Absolutely. I mean, because in these patients also there can be cancers. You know about nephroblastomas, and these patients also can have cancers, right? But in these, it's a bit more prominent, and it's a commoner occurrence, and this is the diagnosis that you cannot miss. You cannot miss. You can miss a stone, you can miss BPH, you can miss a UTI, and you won't kill the patient. You miss this, you potentially will kill the patient. So you always first, second, third, fourth, fifth, especially painless hematuria, smokers, think of tumors, especially bladder tumors. Okay, so think of these three categories: the small children, the young adults, and the elderly, older groups, right? The three different pathology. So another saying by my guru: any patient over 40 years with hematuria, either painless or painful, assume it's bladder cancer till proven otherwise, right? So you have to do a cystoscopy. I'm not telling that because I'm a urologist and I want you to refer all your patients to me. This is with sincere intentions for the patient, right? Think of bladder cancer and other cancers, first exclude them, then get on with the rest of the management, right? So remember that man, 63-year-old, red color urine, culture positive UTI. That is the ultrasound, and that is the cystoscopy, right? So you can pick up this tumor very early, resect it, and maybe even cure him, or at least prevent him from going into muscle invasive disease and metastasis, right? Okay, so about 10-15 minutes more to go. How about a 57-year-old man, very poor stream, pain on micturition, terminal hematuria. What are your thoughts? 2 months ago, he had left-sided loin to groin pain, right? At that point, he didn't have LUTs, loin to groin pain, but now he is coming with very poor stream, almost dribbling, pain on micturition and terminal hematuria. What is your diagnosis? Very poor stream. He is having severe pain while passing urine.
Stone in the anterior urethra, sir.
Stone in the urethra, but it's mostly a posterior urethra, right? If it has come down the ureter, now imagine this stone has come down the ureter, it's coming down a tube which is about 2-3 French insides. Urethra is 30 French insides, right? If it comes to the anterior urethra, this will not stop here. With the urine flow, it will just flush out. The only point it gets blocked is just above the, you remember the rhabdosphincter, right? And the muscles around here. That is the membranous urethra, very narrow area. That is where the stone will get impacted. Can you see that stone very nicely, very clearly? Yeah. So that is a stone that is stuck in the prostatic urethra, right? Classical features. So this patient, you may be able to manage conservatively with some alpha blockers and watch and wait. If he is unable to, because it's a long, thin kind of stone which may trickle down the urethra. So this kind of patient, you tell him to take tons and tons of water, try to flush it out, right? Otherwise, you can go in and put a cystoscope and crush it, maybe, or just pull it out in mass, right? Okay, so so this is another patient, similar type of thing, like that older man. Now, common case scenario that we see, 45-year-old female who has features of a UTI, clear cut, right? And gets treated and may have been actually a UTI, but the only thing is that there is hematuria, right? There is hematuria. Treated with antibiotics, fever, everything, I mean, all the symptoms settle because they have been maybe in a UTI and becomes asymptomatic, right? Then again treated with similar symptoms for another UTI, right? So at that point, what happens? At that point, starts to again develop hematuria, and then the bladder ultrasound shows a bladder growth, right? So ultimately, the patient endures a delay, a physician delay of 4 months, and therefore there is a delayed diagnosis, right? So if anybody in that age group comes with hematuria, even if the culture positive UTI, you always need to look at a secondary cause. So as we thought of and decided previously, do the investigation. If there is hematuria or a UTI, find out if there is a secondary cause, right? Do an ultrasound. Everybody will not deserve a cystoscopy, but if there is hematuria, yes, they will deserve a cystoscopy. Okay, now this is also another common scenario that we see, 23-year-old athlete, visible hematuria. Then, so there is blood in the urine, ultrasound, culture, electrolytes, X-ray, everything is normal. What do you want to do? Or what is your diagnosis? Now the hematuria is nicely settled.
It could be runner's hematuria.
Yes, that's right. Yes, both of you are correct. Yeah. So So this is exercise-induced hematuria, right? So this is not myoglobinuria, right? Sometimes people who undergo severe exertion then can have catabolic events where the muscle is sort of catabolized, and that can cause myoglobinuria or hemoglobinuria, right? If the erythrocytes are normal and it stops after 72 hours, you don't, in a healthy adult, you don't need to actually chase after it. So these are common scenarios where you diagnose this exercise-induced hematuria. Sometimes it can be a little tricky to deal with. Sometimes we tell them have a half full bladder, right? Sometimes when the bladder is completely empty or completely full also, generally when it's completely empty, they can be predisposed to having this. So we tell them to have a kind of a half full bladder at least before they start, and and to hydrate themselves obviously right throughout, and reassure them and tell them to go on with it. Generally it sort of settles down, right? It's another case scenario, 23-year-old, otherwise well female, comes with visible hematuria, and what we find is that the patient is in clot retention. So what does clot retention imply? Obviously there is a clot, but the formation of clots mean what?
Upper tract bleed.
Sorry? Yes, somebody said something.
The bleeding is higher up.
Yeah, it's I mean, if it's getting retention, yes, bladder above, yes, but what else? What else? If, I mean,
Huge amount of bleeding.
Yes, that's right. It's a gross hematuria, and it's a very large quantity, large degree of hematuria, right? So how can you tackle this situation? How can you tackle this situation?
Recording stopped. Recording in progress.
So all these tests are done on this lady, right? They except for the RBC, there is nothing in it. So just apart, how do we tackle the when a patient comes with massive hematuria and clots? What is your plan? What is your plan?
Irrigate the catheterize and irrigate.
Yeah, catheterize. So catheterize with what?
A three-way catheter.
Yeah, large bore three-way catheter. I mean, you're talking like 22, 24 kind of large bore catheters, and then you do a bladder washout, get as much clots out, and then you start irrigating and try to prevent the bladder from going into a complete blockage situation, because the other thing will be, if that doesn't work, then what else will you have to do? You have to take the patient to theater, isn't it? And that's a unnecessary stage if you can manage it conservatively in the ward itself, right? So these are the situations when sometimes you have to think of other causes, right? Other causes of hematuria, those small footnotes that I showed you before, in especially younger patients, because sometimes these patients come with recurrent episodes of bleeding, right? So what are so CT-IVU done, all these things are done, nothing. So what else are the tests that you can think of, and what are the diagnoses that you are thinking of? Any other things, dependent 23-year-old otherwise well patient? What are the causes?
So we could check the protein profile.
Yeah, okay, yes, we check the clotting profile. Sometimes, it can be the first sort of presentation of some clotting abnormality. Yes, absolutely. What else? In a young patient, think of, not neoplasms, very rarely can be very tiny tumors up in the kidneys, right? Which may not be seen. Okay, so you may do a renoscopy and endoscopy and have a look and see. Yes, what else? What else? Anything that people can maybe be born with, or
AV malformation?
Yeah, absolutely. Just like in colorectal, isn't it? Sometimes colonic bleeds. You all have seen AV malformations, right? Yes, sometimes we do have these problem, right? AV malformations, and so we can do a angiogram, right? Renal angios, maybe CT, and at the same time, if the angiogram is done, selective angiography, they can maybe go and do a embolization of that particular site if there is active bleeding, or if there is rhinoscopy and small tumors, you may be able to see them, right? So these are the very, very rare situations, but you can see these patients. And also in some of our patients, as I mentioned, always think of tuberculosis, right? In hematurias, microscopic hematurias, persistent hematurias, always think of TB, because patients can have subtle TB, right? So you have to look for a previous infection, maybe get a chest X-ray. Sometimes it takes a lot of testing to prove these. Okay, it's very difficult sometimes to prove. Urinary culture, not very very sensitive test. PCR is pretty good. PCR for the antigen, the mycobacterial antigen, right? Urine for AFB. Then maybe endoscopy and biopsy of any erythematous areas in the bladder, ureter, pelvic system. So these are measures, and sometimes we treat empirically also, right? So these are some of the case scenarios that
Recording
these are
stopped.
some of the case scenarios that okay, so Prof. Neville is calling me. So I will hand over to him in another 5 minutes. Hold on, I'm just going to answer his call. Okay, so Prof. Neville will log in about 2 minutes time. Any sort of questions that you all have before I wind up? Any questions?
So for the patient present with hematuria and bladder, suspecting a bladder cancer, the first investigation do the ultrasound KUB or the...
Yes, I think ultrasound is quicker, because a cystoscopy, some of us do have the facility to do it in a clinic setting. Even in the government sector, some consultants have set it up. Private sector, of course, we have that facility. So it may be sometimes, we have the concept of like a hematuria clinic, where the radiologist is in the next room. They will do the ultrasound, and my cystoscopy suite is just on the next room. So I go and, while seeing the patients, I will go and do a cystoscopy. Yes, that can be done. But I think in a typical government hospital setting, an ultrasound will be faster, right? So suggest ultrasound, then cystoscopy. I think in our setting, that would be the correct protocol, right? So ultrasound in a large percentage of cases with a good radiologist, we will have the ultrasound picking up quite a few other bladder tumors, right? So yes, I would go along with ultrasound followed by cystoscopy. Yes.
Thank you, sir.
Any other questions, or Okay. So what I will do is, can I make the batch rep, Ravin, the batch rep, can I hand over the hosting to you?
Yes, sir.
I've just done that. And I told Professor Neville also that you will be the host. And so then you can seek his permission and record this.
Yes, sir.
Right. I will send you the link. I will upload this to to a Google Drive, Google link, and then I will send it to you so that you can share with anybody who wants to listen to. Okay.
Yes, sir. Thank you, sir.
Right.
Hello, are we connected?
Yes, sir.
Okay. They can't hear. Okay, here we go. Yeah, you can hear me?
Hello, sir.
Hello?
We can hear you, sir.
Yeah, right. Okay. Then it comes host disabled participant screen sharing. Should I do?
Yes, I will make you host now, sir.
Yeah, yeah.
So you're the host now, sir.
Okay. Right. Okay, then. Okay, you can see the screen.
Yes, sir. We can see the screen, sir.
Right. Okay. Right. I think today what we will try to do is to cover these areas, urinary tract symptoms, low urinary tract symptoms, and management of that, plus urinary retention. I'm trying my best to make this discussion more kind of exam oriented as we are in the final year. This is a typical case you might get in this type of case scenario. So this is actually the case summary we are supposed to give at the end of a long case. So I have brought it forward. So a 65-year-old male presenting with progressive difficulty in passing urine over the last 1 year, 2 episodes of acute retention of urine. This is a model summary. And mixed lux without hematuria, nocturia, dyscharge. So this gives all the useful features you have asked in the history. And when you are summarizing, especially
Recording in progress.
Summarizing these, it's important to mention these features there, because the summary, the main principle is that it should be short and sweet, and all the important features have to be there. And as you see here, examination also, it is summarized here. So this can go either way. This clinical vignette can come up in your SQs, or this can be given in the Viva, these findings, or at the end of your long case, this is how you should present the summary. Depending on what you find, you can modify this. Okay, and let us move on. So when it comes to the history, when you are presenting it, we will be watching, basically listening to you to see whether these important features or segments are covered in your history. So most of you all will not find any difficulty in getting the first few things like name, age, and civil status, presentation. But when it comes to presentation, best thing is when it comes to LUTS and BPH case, you start with the description of LUTS. We'll come in a minute. We'll have a couple of slides describing how you are going to describe LUTS. The patient will just say that they are difficulty in passing urine. So you have to go into the details of LUTS and some special features and the progression of the symptoms. And always try to include these so-called non-LUTS LUTS. Okay, those are lower tract symptoms observed by the patient, but they are not strictly categorized under LUTS. So that is hematuria, nocturia, loin pain, so on. And then this part, of course, most of you will do successfully. But when it comes to the second part, some people forget to take the history in a chronological order. So when you're presenting, just listen to the patient's story and convert that into a scientific presentation, like exactly what a lawyer will do in the courtroom. So from the day one, he has noticed these symptoms, you must say that what exactly he has done. And at the end of it, we should get some idea about the insight of his, what the patient knows about his disease by the time he reached the final center. So, and then this is the most important part of your long case history. It's going to be focus questioning. We'll spend a little time on that in the next couple of slides, because these things, the first few things and these last ones, most of you all will get right because we are prepared for that. But this focus question part is important because that will narrow down your differential diagnosis. So it's important to know all these past medical history, these details, because these people are generally the people who come with LUTs are old and elderly people, and most of them will have these comorbidities, and also they would have been, they will be on various medications, which all going to affect the final treatment. So so it's always better if you can get these details in all patients. And surgical history is also important because that might give a clue to the etiology of the LUT symptoms, and if he comes with acute retention or chronic retention, it will give some clues. So, and allergies, very standard, everybody will ask these things: food, drugs, plastic, contrast, and iodine and blood. Sometimes you forget about blood. So early blood transfusions and reactions you have to include. This is common to almost all the long cases, this type of standard history. So by now you should have practiced these close to the exam especially. And the rest is also very standard. So first examiner will be listening to you, presenting this part, and then this is the focus history. The part of the focus history we expect you to include in your history details. But in between, some of the examiners might interrupt and interview you or ask you why you have asked these questions. So when you are describing the blood outlet obstruction, when you are explaining that he has hesitancy, frequency, poor stream, obstructive symptoms and irritative symptoms, in between there can be a question thrown into you asking why does it cause hesitancy, why does it cause poor stream. Okay, so you should be able to, because they sound very simple questions, but suppose if somebody asks what is the cause of urgency in this patient, okay, what is the reason for frequency, you should be ready to explain that it is the blood irritation or irritation of the trigonal area by the prostate, or sometimes the poor emptying can lead to frequency. Some sort of standard answer you should be ready with, because otherwise you don't expect this type of a question in between the history presentation. So know the pathophysiological basis of the hesitancy, poor stream, urgency, frequency, and all these LUT symptoms. I'm not going to go into details in this because you can refer back to your lecture notes and read around that, but know the background of the pathophysiology of these symptoms. When it comes to acute retention and acute on chronic retention and chronic retention, you have to always ask that in your focus history, whether he has had previous episodes of acute retention, how many times, how it was treated. And sometimes it may be chronic retention, he is already on drugs, and then he might have presented with acute on chronic retention and still being treated for that. So, suddenly when you mentioned that he had acute retention, people might ask, the examiner might ask, what causes acute retention in this patient? What could be the underlying causes of acute retention? So again, you have to be ready with these answers: prostate, stones, urethritis, sometimes post-operative pain. After some unrelated surgery, you know that people go into acute retention. And most of the time when it is asked why, some people won't have ready-made answer. So just know that, or any kind of low abdominal surgery, it may be a herniatomy, it may be a laparotomy. So marginally obstructed patient with BPH or with poor bladder contractions, like chronic retention and poor detrusor power, person with detrusor power, when there is acute the stimulation of sympathetic system. As you know, sympathetics have an inhibitory effect on the bladder. The bladder get relaxed when there's a strong sympathetic stimulation. So you should know when you have postoperative pain and unrelated surgeries in the lower abdomen, how they lead this patient into acute retention. So then the anticholinergic drugs, we may be on anticholinergic drugs for his bowel problems, like, if you have irritable bowel or some sort of a bowel colics, he might be on anticholinergics, and those also can precipitate acute retention. And opioids also well known. So you should be able to explain why the underlying mechanism of acute retention. And then progression of LUTS is the second feature you have to explain. And if it is developed over the years, you know that it could be a prolonged benign prostatic hyperplasia, and its sudden recent worsening has happened, especially an elderly patient in 70s or over 70. You have to always think about prostate cancer superadded on BPH, because most of the patients we get, they present with actually BPH symptoms which have been there for some time, and then when they present to us, it is prostate cancer superadded on this BPH. And if it's a young patient, say in his 30s or less than 40, comes with a LUTS or obstructive LUTS, before thinking of BPH, and you have to think about the other more common causes like with the strictures. And then especially if the patients have neurological problems like maybe chronic diabetes with diabetic neuropathy, and people after maybe after strokes, or sometimes people with Parkinson's disease or some sort of a neurological disorder, they all can present with LUTS. But you have to ask, the important question you have to ask is, what is the timing? Because if somebody says, I have been having Parkinsonism for 10 years, and then he has developed symptoms due over 6 months or 7 months, you should not directly connect that to the neurological disorder. You have to look for a new pathology. But if somebody says that everything started after his disc prolapse or a spinal injury, then of course there will be a major contribution from that to the lower tract symptoms. And then you have to always include, as I was telling earlier, this strictly not LUTS, but associated lower tract symptoms such as dysuria, hematuria, because they will have their own pathology, own etiological factors. So if those are there, those have to be investigated on their own merits. That includes nocturia as well. If somebody comes and you have to, if somebody, your patient complains of nocturia, always get little bit of details about the nocturia, because you have to differentiate nocturia from nocturnal polyuria, because two things, these two symptoms, two etiologies have different management and different underlying causes. That maintaining a bladder diary to see how much of urine is produced or passed during night is very important, because as you know, normal people, the night urine output is not exactly 1/3 of the whole urine output, as theory says, but actually speaking, nocturnal urine output is much less. And if there is a large amount of urine produced during night, that speaks for nocturnal polyuria, and you have to look for the causes like this. Because the moment you say nocturia, there may be a couple of questions asked about nocturnal polyuria as well. And very important thing is with the nocturia, I have mentioned here, if you have nocturnal enuresis, they go sort of hand in hand. Nocturnal enuresis, with Nocturia, if an old person is wetting his blood without his knowledge during his sleep, that can be it's a kind of a danger signal, because mostly it is due to bladder instability and hypercontractility, which happens in this situation called high pressure chronic retention. Because during daytime, he may be passing urine and retaining, and this high pressure chronic retention is not a very common phenomenon. Most of the chronic retentions are low pressure chronic retentions, but high pressure chronic retention can be associated with hypertension, upper tract dilatation, and even renal failure. So this may be the only presenting symptom. So when you are taking the history, be sure that you ask about nocturnal enuresis from this patient, because that's a danger signal. And incontinence, any kind of incontinence, urge, overflow, or stress. As you know, these are the three main categories of incontinence anybody can get. So people with LUTs might have these symptoms. So with its underlying cause, like if it's a chronic retention, this may be overflow incontinence. So acute on chronic retention, maybe overflow incontinence. And if there's bladder instability due to prolonged outlet obstruction because of the enlarged prostate, urge incontinence may be a problem there. And stress incontinence, especially after post-surgery, and that is mostly due to, again, after TURP, if somebody complains of stress incontinence, mostly it is due to urge and stress combination due to unstable bladder. Because post-URP, just remember as a fact that post-URP incontinence is only rarely due to sphincter injury. So if somebody asks at any stage, the commonest cause of post-URP incontinence, just don't say that sphincter injury, so it's a rare thing. Commonest cause is bladder instability, which is getting unmasked after removing the prostate. Then you have to ask few questions about complications, whether he has had complications like recurrent urinary tract infection and stone formation and loin pain, maybe underlying hydronephrosis causing that, and recurrent hematuria, which may be due to BPH. Large BPHs can bleed. And always don't forget to include few of those. There's a long list, good for your medicine exams actually. At least few of these CRF, chronic renal failure features. You have to mention a couple of them, like facial edema or generalized edema, facial edema, things like that. And I'm not going to go into details. You can always refer back and go through these slides. And urethral symptoms is a must, because especially young people, urethral discharge and sexually transmitted disease. There are 10 points we have lined up here. We will be looking at those 10 points when you are presenting your history, whether you have touched on those areas. So moment you have finished presenting the history, next thing will be the examiner will be asking what is your working diagnosis based on this history. So be prepared in this elderly patient, like for any other long case, all long cases. As you know, there are only about 12 or 13 long cases you can get. And all long cases, you have to have minimum of 5 common differential diagnoses in your mind. Otherwise, rest of the discussion is going to be a bit of confusion. So the moment this patient comes to you, so you mentioned, you say that BPH is the commonest cause you think of. So my first diagnosis is a BPH. And then on top of that, if it's say over 70 or so, or recent development of symptoms, you say that next will be the prostate cancer. And then chronic prostatitis, if it is associated with irritative symptoms. Lots of irritative symptoms or storage symptoms, more than the obstructive symptoms, then think of chronic prostatitis. And urethral strictures is important. And then bladder cancer, stones, and infection. Bladder cancers will be generally associated with hematuria, but there can be instances where you can get cancers without hematuria. So you say these things, and then remember, these are all structural causes of LUTs. And then you should not forget to mention, as the fifth cause is much better, functional causes, that is a neuropathic bladder. So this is common to both sexes. And suppose, what is the DD if you get a similar history in a female? So as you know, the LUTs is common to males and females both. So if this question is thrown to you, be ready with a few differential diagnoses for elderly female. Chronic cystitis, or chronic interstitial cystitis, or non-specific cystitis is a common cause. And then overactive bladder, that is idiopathic overactive bladder, where there is a lot of irritative symptoms or storage symptoms due to unstable bladder contractions, is a common cause of LUTs, irritative LUTs. And then atrophic vaginitis and meatal stenosis, again leading to outlet obstruction, could give rise to obstructive LUTs. And pelvic floor descent or UV prolapse, various degrees, and especially in advanced degrees, it can kink the urethra and give rise to outlet obstruction and obstructive symptoms. And Fowler syndrome, if you forget, nobody will cut marks from you, but that is in it comes in relatively young women, and the external urethral sphincter refuses to relax when patient won't pass urine, and it is associated with PCOS, polycystic ovary disease. If anybody gunning for distinction, you can just mention that Fowler syndrome. Okay, so but just know that these common causes in females, and this neuropathic bladder is common to both. Then we will be moving into the examination part. The first examiner will be again listening to your examination finding. So generally the question will be thrown to you saying that, okay, right, what did you find? Always look for the common general examination findings. All medical students go by this. Anemia, edema, jaundice, cyanosis, like that. There's a list which will come to your mind, the exam tension. But remember that if you are mentioning any of these things, be ready to interpret that as well. So, so in general examination, if you look for fallow with outlet obstruction, if you find fallow, always you must say that I will look for a cause, because you can't directly connect fallow to. So if somebody asks, suddenly, why did you look for fallow, and what is the significance if you find these pale? So is it connected to the LUTs? So that sort of a question is thrown at you. You must always be ready by saying that this is part of my routine examination. If he's pale, there's a possibility that this man might undergo surgery later on. So as a preoperative preparation, I might have to find a cause for this fellow and then treat it. So that's why it is important. Rather than trying to think that how can the LUTs is connected to fellow. And again, you can always say that in the CRF, if there's signs of CRF, you can say fellow is part of it. So in general examination, basically look for CRF features. Otherwise, BPH and the prostate cancer, there may not be obvious general findings, but make sure that you have done a head-to-toe examination, front-to-back examination in this patient. All patients, this is a general advice I'm giving you. For all long cases, do a head-to-toe and front-to-back examination. Turn the patient, have a look. Because you might say that there are no obvious physical signs in general examination. Suddenly you find a huge lipoma in the back or in the interscapular area, or there is a little dark melanoma or something like that, or the sign of cut, incision, which patient has forgot to say about a laminectomy or something like that. So if you miss that, that will not be nice for you. So especially if your colleague has found it. So always do a full examination, and even irrelevant but obvious physical signs, like even something like a hemato or a ingrowing toenail or hallux valgus, anything. Yeah, a cataract, You just mention it passing by. That shows us that you are looking at the patient as a patient, and not you are not only looking for the relevant physical signs. So this is a general advice I'm giving. But then you have to quickly move on. If there are no other general physical signs, quickly move on to the abdomen and say that as this patient has lower tract symptoms and history of retention, I have concentrated on abdomen, and most occasions, the patients you will get will not um, again have any physical signs related to his lux in the abdomen, unless he has some incidentally found liver enlargement or something like that. You might not get any. But then the moment you say that there are no relevant physical signs, the natural question thrown at you will be, what did you look for? So what you have to say that is that I just look for ballatable kidneys, bilateral ballatable kidneys, and palpable or percussible bladder, and then look for free fluid. Each you should be able to explain why you look for it. Free fluid, and then don't forget to say, always don't forget to say you look for hernial orifices, and you look for presence of obvious hernias, because this is blood outlet obstruction. So this is generally associated with a direct inguinal hernia. So unless you specifically look for it, you will miss it. And also the patient might have undergone herniorrhaphy in the past. There may be recurrent hernia. So look at the hernial orifices. And even if the patient has not mentioned, you have to either ask or look for hemorrhoids. So if you miss a hemorrhoid, it is, it is not good. So these things in the abdomen, you say that you specifically look for. So then you have to move on to the genitalia. Even if you have in the exam tension or exam heat, you have forgotten to examine genitalia. You always say that to complete my examination, I would like to do examine the genitalia and rectal examination. You know that the examiner will feel a little bad about it, but don't ever forget to examine the genitalia in any patient anyway, any male especially, because genitalia are part of abdomen. So always look for the genitalia, and the special features you will be looking for are going to be penile or penile urethral thickening. You can feel the anterior urethra from top to the perineum up to the bulbourethra. So you feel it. If you feel a cord-like structure, urethra is soft, cord-like structure, you know that this patient may be having a anterior urethral stricture. So on the other hand, look for meatal stenosis and tight phimosis. Some older people with tight phimosis combined with chronic melanocystitis can give rise to retention, because the opening closes, the external meatus closes very tightly. Though generally the phimosis doesn't give rise to any retention. Older people, when it is associated with chronic melanocystitis, it can give rise to retention and poor string. And then BXO is something you have to look for, not to miss. That is whitish patches, vitiligo, associated with meatal stenosis, balanitis xerotica obliteratum. So the newer name is Lichen Planus. It's a variant of Lichen Planus chronicus. It's a skin disease. And don't forget to check the, or at least mention that you would like to examine the testasis and epididymis if you are not done. But that is because outlet people with outlet obstruction will have recurrent epidermocarditis and sometimes thickened epidermal masses and chronic epididymitis. You might feel irregular masses. So just look for that. And if the question is thrown that why did you want to feel the testis, answer is recurrent epididymis. So these interpretations keep in your mind to mention whenever the question comes. And always say that if you are allowed to do the rectal examination, you do so. But otherwise, if he is not allowed, you say that to complete my examination, I would like to do an internal examination, rectal examination of this patient. And you all know what to look for. Starting with the sphincter tone is very important. This is something some medical students forget to mention. In PR, in rectal examination, you always jump straight away and start mentioning about the prostate consistency, loss of median groove, and nodularity and attachment of mucosa. These are all late signs of CA prostate, true enough. But sphincter tone is important because if somebody is having a neurogenic bladder, neuropathic bladder, secondary to peripheral neuropathy or low motor neuron lesion, some disc prolapse or something like that, the sphincter tone is important because that will be low when you have a low motor neuron lesion and when especially the bladder is paralyzed. And then always look for local and vertebral bone tenderness. Those are all metastatic signs of a CA prostate. And the perineal anesthesia, if the patient complains of that, you have to again check it, and lower limb weakness. So remember to mention these things even if you have not done and the time didn't permit you to do these things at the exam. Say that I will be looking for these things. And if somebody asks, the common question asked is that in the prostate examination, what is the most important sign you will look for? The answer will be not the median groove or the nodularity or attachment of mucosa and things. The consistency of the prostate lobe. If it is hard, or if it is nodular and hard, or firm to hard, then there is a suggestion of a cancer. But then granulomatous prostatitis also can feel the same way. So that is not a hard and fast rule. So a few more questions you can be asked during the discussion are, what do you mean by LUTS? Are all your lower urinary tract symptoms called LUTS? Or these are various ways of asking what is LUTS to see whether you know them. So basically you have to remember these things, irritative and obstructive LUTS. These are little mnemonic puff and pins, because there are so many things will come to your mind when you say irritative or storage LUTS and obstructive LUTS. But the important 7 features are coming with this mnemonic. PVR, sensation of PVR means after emptying the bladder, you feel some more is left there. I'm not going to describe everything, very self-explanatory, but remember these puff and pins because these are the important irritative or storage symptoms and voiding symptoms. And also, as we all have already mentioned, there are none lower tract symptoms which are not categorized under classical LUTS, and they all have their different underlying pathologies which you have to read around. And so if there's a question asked, what do you mean by LUTS? You have to, this is the answer to give. And move on, again, some general questions asked are, can you quantify the symptoms? Yes, answer will be yes, because this chart is there just like the Glasgow Coma Scale. This called, you don't have to remember all these things, but if you go through these symptoms, that is the what I've just mentioned, the puffs and pins. Puffs and pins are there. Those 7 symptoms are the symptoms which are categorized under IPSS score. So each one is given marks, and then like PCS score, numbers are given there. If somebody asks, what is the importance of objective assessing these symptoms? You can always say that by comparing the scores, you can see whether your treatment is working or whether the patient is getting better or worse with observational therapy. So be ready with that answer. Okay. So importance of any scoring system is that. So just know about, just be aware of this symptom score. I'm not going to go into this. If somebody asks this, passing by ask the question saying that is LUTS caused by the prostate? Answer is no. Okay, LUTS is caused by the detrusor response to various stimuli and various factors. If you know that answer, that is enough. You don't have to go into details. Those stimuli or those underlying factors are multifactorial. You can see this cartwheel here. So many causes. Leisurely go through them. Try not to remember everything. But final pathway. Somebody asks, what is the final pathway of getting LUTS? That will be the detrusor muscle response to all these underlying factors. Again, few questions asked at the long cases. BPH, BPE, BPO. These words are those synonyms? They are not. You have been taught already this. BPH is a histological change which starts at the age of 35, histological change. BP is enlargement of prostate, because people with BPH, only about 50% will, roughly, this is a rough figure, 50% will have enlarged prostate. Out of the enlarged prostates also, about only 40 to 50% will have blood outlet obstruction or LUTS. So there will be large prostates hanging around without any symptom. So these are the three words you have to. Natural history of BPH, somebody will, if somebody asks that, what happens to the prostate if you just leave it alone, as time goes on, it will shrink. There was a belief that as time goes on, the prostate will shrink into, because it will overgrow its blood supply and it will shrink. But that doesn't happen. Studies have shown that it will keep on growing in size. Some of these facts are for your MCQs. Better to know these things. Then moving with our long case again, and second examiner, the first part will be the once you have given the history and the examination part and the questions are finished, move on to the second examiner. General job is to how do you confirm your diagnosis? There are various ways of asking the same thing. So, I mean, we are also human beings. We can't keep on asking the same thing from 10, 15 candidates. So we change our words and the way we ask. So, but we are asking the same thing. And even SCQ can come saying that how would you evaluate this patient? Same thing. So, and then the last part of the second examiner will be giving a case scenario and asking you how to manage. Let us move on fast because of the time restraints. How would you start investigation? Always, if you say management in a CQ or question, always think of investigation and treatment both. So management means investigating, come to a diagnosis and treating. So, but when you ask investigations, always start with the simplest investigation. So urinalysis, hematuria, pyuria, proteinuria, crystalluria, those are the few things you have to look in the urine. Whenever you are presenting, when you are answering, if I ask what are the lab investigations you would do, you will tell this and then give the interpretation immediately. Don't wait for the old man to ask, why did you do a urinalysis? What information are you going to gather? How is it important in LUTS? So without waiting for those things, get used to the habit. When you are practicing presenting these long cases or viva, you give the investigation and straight away say that I will be looking for these features like hematuria, pyuria, proteinuria, crystalluria. So if you have practiced it, it will come to you. Then next will be serum creatinine for global renal function, which will show us whether these LUTS or the disease causing the LUTS has affected the kidneys or whether he has any other comorbidity which is disturbing the global renal function and which will be important in managing the LUTS. So those are the two reasons why serum creatinine and assessment of global renal function is important. So, because if you are ready for these type of answers, that is called exam prep. Exam preparation is different from studying. So you are ready to answer. Then full blood count is always, to exclude superadded infection. You can always say CRP and full blood count. A PSA if you are suspecting associated prostate cancer. And imaging, when it comes to imaging, ultrasound and uraphometry is a must. For all low interact symptoms adults, these two are a must you have to mention. And if somebody says that what is the place of IBU or CTU, MRI or contrast studies, these are all together called contrast studies or advanced imaging. There is no routine indication. Guidelines won't say any indication. So unless there are specific features, like you are suspecting there's hematuria and you are suspecting a genitourinary malignancy, then you might go into do these things. And endoscopy. When it comes to endoscopy also, like cystoscopy, flexible cystoscopy, if somebody asks, should you do an endoscopy on this patient with difficulty in passing urine? Elderly patient, if the other investigations show that this is very likely to be a blood outlet obstruction due to a BPH, if there is no hematuria or there is no suspicion of a uterine stricture, there's no indication for endoscopy. Especially if a young patient, 30-year-old chap comes with a urinary tract symptoms, with a history of urethral discharge, then of course the endoscopy might have a place because to exclude the urethral stricture, but not to a straightforward person with BPH without any other associated symptoms. Again, this if you're recording, I think all of you can go through these things and see. These are the investigations to be done and with the interpretation of. Because remember that when you are mentioning this particular patient, you have to go in this order of simplicity, because don't straight away go for the last few ones. They have their own special indications. What information would you gather from ultrasound is again another common question asked at various stages. So these are the information gathered from ultrasound done for a patient with urinary tract symptoms, prostate volume, and this is something new for some people. Intravesical prostatic protrusion is how much of the median lobe or the prostate is protruding into the bladder. It has been shown recently that if this protrusion length is over 1 centimeter, there is a higher chance of the person going into retention, and their response to drug therapy will be low. So that is why this is important now, and some of the radiologists, they measure this separately. And residual urine is a must, that is pre and post void residual urine, that will show how badly the outlet is obstructed. And then bladder wall thickness, presence of hydronephrosis are very useful information, and rarely you will find a loosened stones which have not been picked up earlier in the ultrasound or in the X-rays. And transrectal ultrasound is a modification of ultrasound which is used to get biopsies for clear prostate. Then about uraphometry, you have to know a few things about uraphometry. What is it? Because in hospice, at hospice, you can get one of these tracings here, because it's very commonly done investigations nowadays. So if it is pasted here with a short history of a man with outlet obstruction, you should have some idea of what it is. So uraphometry is the speed of passage of urine measured every second with the speed, and this is the machine. If you have not seen it during your urology appointment, make sure that you see this at least in a YouTube video. So there are various types of graphs are there, and you have to know what is the normal shape of the graph, bell shape, and generally graph finishes in 30 seconds or so. And there are various other shapes which you can, this slide is self-explanatory. By studying the shape, you can guess what is going on like in the outlet. Then the few questions about PSA can be asked, and what is not true about PSA. This is an MCQ actually. I'm not going to ask you to answer. Just know a few basic facts about PSA. Okay, serine protease enzyme is right, and it is amounts released to blood after urethral increase amounts. Any kind of manipulation, urethral or prostatic manipulation, will release some prostate PSA into blood. That is true. Produced and secreted into blood by prostatic epithelial cells, which is the wrong answer. So this is the best of 5 answer. So which is the wrong answer, because PSA is secreted into semen, not into blood. So remember that. So this only one word is wrong here. And it helps to liquefy semen coagulum deposited in the vagina. So that is the physiological effect of PSA, which is an enzyme, human kallikrein enzyme. So that is the function of that. And unbound fraction is lesser than fraction bound to antiprotease complex PSA. That's also true. So you just go through these MCQs. There are so many. It's not the time to discuss those. And conditions which will affect the PSA, most of you know that. Any kind of manipulation, malignancy is the number one we think of, but then the size of the prostate matters. Larger the prostate, higher the PSA, because it secretes a lot of PSA into blood. And infection, inflammation, trauma, and don't forget about the drugs. But there are several drugs which will reduce the PSA levels in the blood, especially the prostate, the drugs which are used to shrink the prostate. 5-alpha reductase inhibitors. When you give 5-alpha reductase inhibitors, there is about 50%, as expected, about 50% drop in PSA levels. So thereafter, what the PSA levels you get are wrong because they are not correct. You have to multiply roughly multiply it by 2, large prostate especially by 2 to get the correct PSA levels when people are on ARIs. So, and anti-androgens also will drop PSA levels due to obvious reasons. Let us move, and a few questions can be thrown to you. How to treat. Now, this is the last part of the discussion, how to treat this patient. So, lifestyle adjustments, you have to start with by saying that if this patient has low IPSS score, that is mild symptoms actually doesn't carry a meaning. There's no meaning. That's why International Prostate Symptom Score is important. But if you say that the low IPSS, so that is about 1 to 7 or so, and there are no complications of BPH, outlet obstruction complications like infection, large residual urines, upper tract dilatation, and things like that. No complications, then they can be managed with lifestyle adjustment, and avoid excessive fluid intake. So there are people who will drink fluid for anything, whether it is corona or whether it is outlet obstruction or whether it is stones. So they think that drinking a lot of fluid will help. It helps, but it will make the matters worse in outlet obstruction. So you ask them to just drink when you are thirsty, and avoid drinking in the night after 5 o'clock, because there are a lot of people, the nocturia is due to excessive drinking in the evening. So you cut down the evening fluid intake. Time voiding and double voiding is important for people who have fair bit of residual urine in their bladder. When there is residual urine in their bladder, there is no other complication. That itself is not an indication to go for any intervention, either surgery or not even, sometimes not even to start drugs. It's a small amount of post-void residual, double voiding, and time voiding, that is not allowing the blood to fill up, overfill. You empty the bladder by the clock, 8 o'clock, 12, 4, and 8. And each time you pass urine, you empty it twice. And timing of diuretics is also important. Some people, without their knowledge, they take their diuretics and diuretic combinations of hypertensive drugs late in the day. And then that can lead to nocturia because diuretic effect takes place in the afternoon. So rushing through the medical management, these things are mostly done in your exams. I'm just recapitulating your knowledge in this CLD. Medical treatment, when it comes to medical treatment, it is again for intermediate LUTs, and then mild or intermediate LUTs with low IPVSS. You can start medical treatment. Uncomplicated BPH, again, medical treatment is the first line. And nowadays, over 70 to 80% of people with LUTs are managed with medication, and only a minority will go through surgery. And the contraindications, there are absolute contraindications are there. And this absolute contraindication is upper tract dilatation, which is especially leading to or contributing to chronic renal failure or renal failure. So sometimes the renal failure may be due to something else like diabetic nephropathy or a hypertensive nephropathy. But if upper tract dilatation is also coexisting, especially, there's absolute contraindication to try for go for medical treatment. And poor progress with drugs, again, you have to stop drugs and move on to surgery. And when there are side effects of drugs, severe side effects of drugs, you have to give up. And the dual therapy and triple therapy are there for prostate, as you know. Alpha blockers, they relax the bladder neck and the urethral musculature, and also the prostatic musculature. When some people are asked whether prostate has muscles, there are a few people who will wonder. There are spiral ring of prostate smooth muscles which surrounds the urethra. That's why it's called fibromuscular hyperplasia. And so those muscles all get relaxed when you give adrenergic blockers, because these muscles contract due to adrenergic stimulation. So important thing about adrenergic drugs is that it acts within 24 hours and its effect lasts only for 1 to 2 days. So if you forget to take the drug, the muscle tone will come back and your symptoms will return. So when you are prescribing it, you have to always tell the patient that this is to be continued for a long, long period or until you undergo surgery. And when you combine it with 5-alpha reductase inhibitors, is the long-term solution for the prostate. And what you must remember is that 5-alpha reductase inhibitors will start working after 6 months. So after 6 weeks, these 5-alpha reductase inhibitors will dry up the prostate. They will reduce the vasculature. And then if you are planning for surgery, it may be advisable to start a 5-alpha reductase inhibitors. And after 6 weeks, their bleeding tendency is much better. But the shrinkage will start after 6 months and it will be completed after 6 years. So 6 weeks, 6 months, 6 years. Rule you have to remember when you are using finasteride or dutasteride. And anticholinergic therapy is the third drug, the triple therapy. Usually these two are enough. But if the patient is having a lot of irritative symptoms like the storage symptoms, you can add anticholinergic drug. Usual notion is that if you add anticholinergic therapy, bladder will go to sleep or get relaxed, and you can go into retention. But that doesn't happen in practice because if you combine that with the other two drugs, it doesn't happen. But you have to always remember a golden rule that if you are giving anticholinergic therapy, there shouldn't be a post-void residual over 150 cc. If somebody is having a large post-void residual, especially over 150 cc after voiding, you should not prescribe this third drug or anticholinergic drug. New drugs coming into the scene is PDE inhibitors or sildenafil tadalafil, which are prescribed for erectile dysfunction as a smooth muscle relaxant in the penis. But it has been shown very clearly, you can see this graph here, that these drugs act on the bladder neck and the other smooth muscles as well. And it can be effective just like alpha blockers. So you can either replace alpha blocker and especially if the patient is having erectile dysfunction associated with prostatic symptom, you can use PDE inhibitors in a lower dose as a regular medication for this. These are all, I think you don't have to remember these things. Basically, question asked is one alpha blocker is better than the other? It is efficacy is same, nothing is better than the other, but only thing is that side effect profile is different. If you give the older alpha blockers like prasosine, they cause postural hypertension, and the newer ones are more uroselective, like samsulosine. And silodosin is the new one, which is not included in this chart. They are more uroselective, and their side effect profile is low. But when it comes to efficacy, remember in MCQs, this will be sometimes included. Efficacy-wise, it's all same. Alpha reductase, 5-alpha reductase, one thing I have already mentioned that, I'll rush through this. No need to go through that. Remember that PSA levels will go down with alpha blockers, 5-alpha reductase inhibitors. So whenever you are doing a PSA with patients on alpha blocker, 5-alpha reductase inhibitors, remember that is a wrong figure. And 5-alpha reductase inhibitors will work only on large prostate. So there's absolutely useless giving a 5-alpha reductase inhibitor to a 10 gram or 20 gram prostate. So this cutoff line of 30 or 35, some people, or the prostate is taken when you are prescribing these prostate shrinkers, alpha 5 ARIs. So otherwise, the patient will be taking this for 5 to 10 years without any effect. So prostate size has to be around, some people take it 40. So it has to be generally a larger prostate. Various guidelines give various things, but don't prescribe it to tiny ones. Side effects are given here. And finasteride and dutasteride both, 5 ARIs, main side effect is erectile problems. So you have to warn the patients. And I rushed through these things. There are no point. These are all one of the very famous studies, this MTOPS trial, which is the one which introduced 5-ARIs as treatment. And this is the reason why we are giving the third drug, anticholinergic drug, because as time goes on, overactive bladder overactiveness increases with age. Nothing to do with the BPH. Whether there's BPH or not, the bladder starts shivering as time goes on. So if there's a lot of irritative symptoms, it is always better to add an anticholinergic drug. So this is something again asked at the discussion. What are the absolute indications to undergo BPH surgery? If you are doing surgery, absolute indication. So absolute indications are upper tract dilatation. If somebody is having outlet obstruction and upper tract dilatation, there is no place for drug therapy. Obstructive CRF, I have already mentioned, and chronic high pressure retention. The chronic retention, generally people don't actually operate or catheterize if the upper tract are safe. If somebody is emptying his bladder, but there is a lot of residual urine there, you advise him to practice double voiding and time voiding and things like that. But you don't straight away go for surgery unless chronic retention gets complicated with infection or stones. But this special situation where chronic retention is associated with upper tract dilatation, there's no place for drug therapy, straight away for surgery. And then the failed drug therapy is important because while on drugs, if these things are happening, then that's called drug failure, you have to go for surgery. Relative indications are the patient's choice. And but first AUR, acute retention, is not an indication for surgery nowadays. After first AUR, you give the patient an alpha blocker trial. You give him alpha blocker for theoretically 24 hours, but practically at least for about a week or two, because for the prostatic edema to settle, and then give one trial, and then if it fails only, you go for surgery nowadays. So first AUR is not an indication for surgery. Types of surgery, I don't think we have time to go into these. Just know that there is a wide range of surgical interventions available nowadays. I think when you are bored of studying boring topics, just go through these techniques. This slide is with you. So there are various new techniques are coming up, but still the gold standard of removing the prostate is transurethral resection of the prostate. And we can use either water or saline. When you use saline, it is called Turis. And there are various new energy sources which are used to remove the prostate. But when it comes to the final outcome, none are superior to the transurethral resection. Okay, but the new methods are there. Just read around that for your interest, like aquablation, resume, urolift, like stapling the prostate. Funny things are coming up. They are now, some of them are in practice, but we don't know how long they will last. Okay, but when your time permits, just go through this racially and know, because BPH is a common problem. And this I'm going to rush through. I'm not going to, you can go through these things with the slide set. Enucleation of prostate is the older technique, oldest one. We still do it. The current indication is only for 100 gram or a large prostate, very large prostate. Even that now we don't do, because in specialized centers, highly specialized centers, what we do is we do endoenucleation. We put the resectoscope inside. Rather than cutting this, we do the same thing. Use the resectoscope instead of the finger and enucleate this from inside and drop it to the bladder and suck it out with an instrument called Morsellator. So that is called endoenucleation or endomilins. So these 100 gram prostates, we do either open prostate or enucleation. You can use either laser or the current diathermy to do that endoenucleation, but that is done in only few centers. TURP, you have to know a few things about these to answer your MCQs. Is the time going to be a problem now? I can stop at this. Hello?